So hello everyone, and welcome to this advanced coding webinar. And welcome back if you were attending the MedDRA Coding Basics webinar last week already. It is nice to meet you again or meet you for this webinar and to go through some additional, more advanced aspects, examples and exercises and on how to perform MedDRA training or MedDRA coding, so to say. I'm Carol Ann Wilson and work as a medical officer at the MSSO. And as you heard, I'm supported by my colleague Leander Mold, who was speaking to you before. So together we will take you through this webinar. And we would like to make this webinar interactive. So please submit your questions or send us your comments through the question panel. Leander mentioned this already. I will allow as much time as possible for questions both during the course and also at the end of the presentation. Now let's start with some general slides first. Most of you will know that ICH adopted the development of MedDRA in the mid-90s and became finally the owner of the terminology. ICH then, on contract, appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback, also to provide and organize corresponding training as the one that we have today, and to administer the MedDRA licensees. And all these MSSO activities are overseen by the ICH MedDRA Management Committee. ICH is not only the owner of MedDRA itself, but also owns this training material. So it is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the content of the slides have to be clearly labeled. And the second bullet point here refers to warranty and liability issues you should be aware of. And the third one is not relevant for today because we will not be using any third-party slides. These are the topics that we will cover today. We will first discuss some more advanced principles that are outlined in the Points to Consider document for MedDRA term selection, which is a coding guidance document provided by ICH. We will then look into the MedDRA concept descriptions and at several examples, several advanced coding scenarios. We will use Poll Everywhere, a quiz tool, and the MedDRA browser to apply some of these advanced concepts from the PTC document. And finally, we will go through some tips for coding, what we call the coding pearls, to help you with your coding tasks. And we will conclude with a question and answer session, but as mentioned earlier, you will be able to raise questions throughout the session as well. But please understand that it is not in the scope of this training to help you with very specific verbatims that you came across, but we will rather address the advanced coding principles pointed out in the Points to Consider document and related coding scenarios that we will work on, just on a more general level. Now let's start. The next two slides now explain about the polling. If you would like to join the quizzes and also participate in the examples and exercises today, there are two ways to do so. The easiest way is to scan this QR code with your smartphone or tablet, and it will bring you directly to the poll. Or you may enter the indicated web address here, pollf.com, into the URL bar at the top of your internet browser in your computer, tablet, or cell phone, and it will then bring you to a log-on screen, and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my user ID, that is Carol Ann Wills 584 with no spaces. Nothing more needs to be entered, just click join then. And Leander has put these credentials in the chat as well. You don't have to get under time pressure because you will be able to see these credentials on each slide that relates to the quizzes. And I can also show the QR code in between when we are working on the exercises. So now let's see whether this application, this tool works. Oh, it does. So nice to meet you all. I see South Africa, I see Tunisia, people in India, I think it's Vietnam maybe, Philippines are with us, China, Kazakhstan, many people in Europe. I see Mauritania in Africa, also Kenya, I think, and North America, US. It's either very late for you or very early. So nice to meet you all. Welcome. I'm sitting in Berlin in Germany, and yes, I'm really happy to welcome you all. Now, please let me know whether you have already attended the Coding Basics webinar. I see that many of you did so or are already more experienced MedDRA coders. But for all others, it is really helpful to attend the Coding Basics webinar as well, because it will provide you with important information about the MedDRA structure and some basic principles that should be applied in operational coding that are addressed in the ICH coding guidance document. Our webinar today builds on it, and I will not be able to go into the details of what is covered in the Coding Basics webinar. Now, let us start with our topic today and first look at the MedDRA term selection points to consider document that provides guidance for operational coding. This is a screenshot of the cover page of the current ICH PTC document for MedDRA term selection for version 27.0. It provides guidance and many examples on how to perform accurate and consistent term selection using MedDRA. This guidance should be the basis for your coding decisions, and with this approach, the ICH promotes overall coding consistency and also facilitates common understanding when sharing clinical data. MedDRA allows us to speak with one language when sharing medicinal product safety information between different biopharmaceutical companies, between pharma and CROs, or when talking to regulators. The document was developed and is maintained by an international expert working group appointed by the ICH MedDRA Management Committee with members from regulators and industry of the ICH regions, the MSSO and the Japanese Maintenance Organization or JMO, and the WHO as an observer. There is one original and comprehensive version that is available in English, Japanese, Chinese, Korean, Spanish, and Russian. It is updated with each major MedDRA version release. That means beginning of March each year. In addition, there are condensed versions of this original document in other MedDRA languages, except those that I've just mentioned, of course. And you see these languages listed on the slide: Arabic, Brazilian Portuguese, Czech, Dutch, French, German, Hungarian, Italian, and Portuguese. These condensed versions focus on the general coding principles without going into further details for selected topics. They are not updated with each MedDRA release, but on an as-needed basis, because the general coding principles do not change so much. The Coding Basics webinar focuses on the basic principles for term selection that are outlined in the first part of the PTC document. Today, we will focus on specific coding topics, not the general principles, so more advanced ones that are addressed in the second part of the PTC document. And you see the list of these topics here. like diagnosis and provisional diagnosis with or without signs and symptoms, how to deal with death and other patient outcomes, how to code suicide reports that relate to suicide, self-harm, what to do with conflicting, ambiguous, or vague information, how to deal with combination terms, body site versus event specificity, how to prioritize this information, neoplasm terms, investigations, and we will cover quite a few of these advanced concepts today, those that are highlighted in yellow here, either in separate slides or via practical coding exercises. And the list continues on the slide. You see that the document also addresses medication errors, accidental exposures, occupational exposures, misuse, abuse, addiction, device-related terms, how to code medical social history, indications for product use, off-label use, product quality issues. So a lot of information in this document. And the ones highlighted in yellow again, we will address today. Let's first start with some important general principles which are addressed in the PTC guidance. We have already discussed them in more detail last week in the Coding Basics webinar. Coding is done on LLT level, the data entry level, and only current LLTs must be used in ongoing coding. The LLT selected should capture as much information provided by the original verbatim as possible. As can be seen in this example here. Reported is an abscess on the face. So abscess is the condition of interest, and we have the manifestation site, the face. So here we should not simply just select LLT abscess in order to capture the condition, because it is medically relevant to also capture the manifestation site. So we would select LLT facial abscess in order to capture as much information from the report as we can. And facial abscess is a separate PT, it's a subcutaneous, is grouped under subcutaneous abscess, and of course a cerebral abscess, pulmonary abscess, they are all represented in separate PTs. Always, and last but not least, always remember to select current LLTs only. The non-current LLTs are still in the terminology for historical purposes to support the interpretation of legacy data and also legacy data conversion, but they should not be used for ongoing coding. In some instances, you may consider to select more than one MedDRA term to capture the full information of the verbatim. So let's look at the example on this slide here. If you are to code the verbatim metastatic gingival cancer, you may decide to select either gingival cancer or LLT metastatic carcinoma to not duplicate the event. But the selection of only one term will lead to loss of information, of course, and you would need rules also for the prioritization of the information received to ensure coding consistency. But you may also decide to capture the full information and split code by assigning both LLT gingival cancer and LLT metastatic carcinoma. And when taking this approach, you would duplicate the event that is the malignant neoplasm information. In the end, you are free to choose either option, either lumping together this information and only selecting one term, or by splitting. But make sure that you document your rules and that they are used consistently. Now let's look at an example for this principle. How would you code left foot and ankle swelling? Would you select LLT peripheral swelling? Would you split code and select swelling of feet and ankle swelling? Would you select unilateral leg swelling? in order to be more specific here, because the leg is affected, or just local swelling? What would you do? Left foot and ankle swelling. Split or not split is the question. I see many of you have voted already. Nearly 100 votes we have already. Yes, and most of you are going for splitting, and that's correct. Let me close this poll. Here we are. So some of you have also selected peripheral swelling or unilateral leg swelling or local swelling. So let's look at the verbatim again. The correct approach would be splitting and selecting two LLTs, namely swelling of feet and ankle swelling. And this is because LLT ankle swelling, the ankle is considered a joint in MedDRA. So ankle swelling is grouped under PT joint swelling. It's a separate concept, whereas swelling of feet is grouped under peripheral swelling. PT level is the medical concept level, and it's always, if you have information that relates to different PTs, then usually you need to split code. So this is why in this instance split coding would be necessary. Next one, how to code pain in hand, severe pain in leg and toe. What would you do with this one? Would you code to pain or musculoskeletal pain, or would you split code and select pain in hand, pain in leg and pain in toe? Would you select pain in extremity? Or would you split code into pain in hand and pain in leg because the toe is part of the leg? What would you do?
Caroline, could I interrupt you? Just yes. Could you show the QR code again? Make yes. it larger for me. Thank you.
Okay, so I see many of you have voted already. So many of you would split code here. But we have, so the majority would split code. Let me close this poll again. And here's our verbatim. So here we have a different scenario because all reported events can be coded to LLTs that are grouped under one single PT. And this PT is the PT and LLT pain in extremity. So in such situations, you would select the LLT that is identical to the PT name. And you can see that, like in the other example, checking the hierarchy is really important. Pain in hand, pain in leg, and pain in toe are LLTs that are grouped under one PT that is pain in extremity. And that's why in this instance, no split coding is necessary. Because data analysis is performed on PT level, you would duplicate the event pain in extremity by split coding here. That's why one code would be sufficient, and that would be the LLT that is identical to the PT name, pain in extremity. As indicated before when showing the splitting examples, checking the hierarchy is really an important general principle for term selection. Before making a coding decision in more complex cases, it is always advisable to check the MedDRA hierarchy to reassure yourself that you are on the right track, that the selected LLT actually is medically correctly presented in the MedDRA hierarchy. And as an example, a non-infectious condition should not be represented in SOC infections, or a condition which was acquired later in life should not be coded to a term in system organ class congenital. The slide provides an example. If you are to code the verbatim feeling completely drained, you won't find an exact match in MedDRA. So you may then consider to assign LLT worn out, but may be unsure whether this is appropriate. But when checking the corresponding PT fatigue and the LLT siblings underneath, like for instance, LLT exhaustion or LLT tiredness, you will feel much more comfortable with your coding decision. So checking the hierarchy is always really helpful. And when not checking the hierarchy, you may even end up with a completely incorrect code assignment. If a patient suffers a ventricle rupture due to a pre-existing hydrocephalus, the assigned MedDRA term should reside under SOC nervous system disorders. So the correct term would be LLT cerebral ventricular rupture, same PT. When searching for ventricle rupture and not checking the hierarchy, one may assign LLT ventricle rupture. It seems to be a perfect match. But this LLT and PT is grouped under HLT myocardial disorders, not elsewhere classified, and resides in SOC cardiac. So this is a real-life example that I came across when doing spot checks of code assignments when working in pharma. So always relevant to check the hierarchy. It's not a big deal, doesn't take much time, but it will really prevent you from miscoding such events. Another topic that I would like to highlight today are the concept descriptions. These are descriptions on how a medical concept is interpreted, used, and classified within MedDRA. They do not represent medical definitions like you can find in Dorland's or medical textbooks, but they may be helpful for you when searching for suitable LLTs. The purpose of the concept descriptions is to support accurate and consistent use of MedDRA in coding and data retrieval, and they intend to help to overcome some differences in the use of medical terms worldwide. You will find the concept descriptions in Appendix B of the MedDRA Introductory Guide, but you can also access them in the MSSO MedDRA browsers. If you click on the icon on the top of the MedDRA browser, this window will open here. And you can then select the appropriate section to view as the concept descriptions are sorted in alphabetical order. So now let me show you. Let me go to the MedDRA website. So here is the web-based browser, the shortcut. If I click on it and select English, and I will need my MedDRA ID and my password, and here we are. So here are the MedDRA concept descriptions. If I click on it, this window will open, and then you can, let's look at cancer, carcinoma. So here's an explanation what cancer means, and what is really important to know is that in the context of MedDRA, carcinoma and cancer are considered synonymous. So carcinoma terms are generally subordinate to cancer terms, like LLT skin carcinoma is linked to PT skin cancer. So these are the concept descriptions and the descriptions that you can find in this section. So let us look for dose. Here we are. Dose is referring to a quantity to be administered at one time, such as a specified amount of medication, whereas dosage is much broader. Dosage refers to the determination and regulation of the size, so the dose, but also the frequency, the schedule, and the number of doses, so the duration of treatment. It covers much more. And if I look for overdose, for instance, here we are, overdose. For the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose in quantity and/or concentration, in other words, an excessive dose. And what you also find in these concept descriptions are terms that relate to product quality issues. So abnormalities that may be introduced during the manufacturing, labeling, packaging, shipping, handling, or storage of the products. And you see some of them here: product taste abnormal, or product odor abnormal, or product color issue, for instance. So do we have questions so far, Leander, before I continue?
We do have one. Thank you, Caroline. Yes, we have one question. It relates to split coding. Please, can you explain how to avoid double counting when split coding?
Yeah, that's exactly the issue. You know, when you split code, your database will get more complex, and also the retrieval of data will get more complex. That's the disadvantage of the splitting approach. On the other hand, if you rather if you decide to lump this information and only assign one code, you just omit information that may be relevant and may also be difficult to interpret the data based on listings at the end. So there's pros and cons for each of these approaches. It really depends on your decision. It's a difficult decision, I have to say. So in my previous company, we tended to split code, and somehow we managed, but in order to not omit any relevant information. But I know that other companies rather tend to lump information and to only assign one code in such scenarios. So there is no black and white answer that I can provide in this respect.
Thank you. We've had another question as well, if I may. Does overdose refer to a one-time dose or the daily dose, or to both?
It refers to it refers to primarily to one dose. But of course, if you are to difficult question. So I would say it refers to one dose, but if you have, for instance, if you provide a drug in the correct dose that is to be administered once a day, and it would be administered 3 times daily, then you would assign a different LLT. That's a schedule issue, because it's the drug is provided more frequently, and you find respective LLTs in MedDRA. So this is how we handled it. But you may also decide to say, well, if you have a drug that has really a very narrow safety margin, to take a different approach. This is really also a product-specific consideration. Yeah, if the margin is very, very narrow, then it would of course already be an overdose if you provide a once daily dose 3 times daily. Again, there's no, sometimes it needs some discussion and also decision making in order to come up with a correct solution for such scenarios. Additional questions, Leander?
No, there's no other questions. There was just one more, but it was very specific. So okay. I'm just writing back to the person. Thank you.
Thank you. So let me continue here. And here we are with our slides and continue. So now we will address some of the specific advanced principles in the PTC that are mentioned in the PTC term selection guidance document. And the first advanced principle in the document is the coding of a confirmed or provisional diagnosis with or without signs and symptoms. Well, if we have a single diagnosis without signs and symptoms, which is confirmed, we will only code the diagnosis, because this is the only information that we have, of course. If a provisional diagnosis is reported, without signs and symptoms, we would take this suspect diagnosis as if it was confirmed and code it accordingly. In parallel, of course, we would ask the reporter for more information, whether it was meanwhile confirmed or whether there was another diagnosis at the end. And the same approach would be taken if you have multiple confirmed or provisional diagnoses without reported signs and symptoms. Next, we have a different coding scenario where either a confirmed or provisional diagnosis is reported with signs and symptoms. For such coding scenarios, the PTC document provides a preferred and an alternative solution. For a definite diagnosis with signs and symptoms, the preferred option is to only extract and code the diagnosis. And here we have an example. If you have an anaphylactic reaction with rash, dyspnea, hypotension, and laryngospasm, you would just code to anaphylactic reaction because these symptoms are all characteristic for the diagnosis anaphylactic reaction. And in the case of signs and symptoms that are reported with one suspect diagnosis, all signs and symptoms and the provisional diagnosis are to be coded. In case signs and symptoms are reported with several suspected diagnoses, all signs and symptoms and all provisional diagnoses are to be coded. Very important to remember because these are really very frequently occurring coding scenarios. So these were the preferred options. Now we are coming to the alternative options. So here, signs and symptoms can be coded in addition to the diagnosis when having a confirmed diagnosis. So in our example, previous example, you would not just code anaphylactic reaction, but we would code to anaphylactic reaction plus code all signs and symptoms. So this would be the alternative approach. And for suspect diagnosis, you can only code the signs and symptoms because the provisional diagnosis may of course change. Again, the same rules apply for multiple confirmed or suspected diagnosis. So both options, the preferred one and the alternative option, can be selected, but the approach chosen has to be applied firstly consistently, and it also needs to be documented in your coding conventions. So taking the preferred option is simpler, would lead to a leaner database, to less noise in your database. When taking the alternative approach, you would be on the safe side, not omitting reported information, but data retrieval and analysis may be more complex. That was a question before about the splitting and lumping. Yeah, if you split, of course, your database gets more complex and also data retrieval and analysis gets more complex, but you don't omit information. You have everything available. And here is the cautionary remark when taking the preferred approach, when only coding the diagnosis, taking the preferred approach for confirmed diagnosis. The PTC document clearly states that signs and symptoms that are not associated with the diagnosis, that are not typical for the diagnosis, will always have to be extracted and coded separately. And honestly, even with sound medical background, this is sometimes hard to decide because clinical signs and symptoms are often not pathognomonic, meaning that they do not point at only one diagnosis, but could relate to many. The example that is provided in the PTC document is quite obvious. Of course, if you have a myocardial infarction, chest pain, dyspnea, diaphoresis, ECG changes, and jaundice, it's obvious that the jaundice really is not characteristic for the diagnosis myocardial infarction. But there are other scenarios where taking this decision is much more complex. So again, it's up to you what you decide to do. Both options have pros and cons. If you don't split code, then you would have a leaner database. If you decide to split code your database, you would not omit information. You have everything available, but your database will get more complex, and this way also your data retrieval and analysis. So let's have a look at another example here. If you had a report about a sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation, how would you code this? Sepsis leading to shock from possible spontaneous bacterial peritonitis or bowel perforation. Which LLT would you select, or which LLTs would you select based on what you've just heard? And please apply the preferred approach. This is what we always do in our trainings. We always take the preferred approach. Let's see what we are going for. So we have septic shock, spontaneous bacterial peritonitis, bowel perforation are the preferred options. Some of you would also code sepsis and shock. So let me close this here. And so we have to capture both provisional diagnoses. These are provisional diagnoses, spontaneous bacterial peritonitis, and the other one is bowel perforation. And if we take the preferred approach, then we would need to code the clinical signs and symptoms in addition. The question is whether we would assign sepsis and shock or septic shock. Septic shock, of course, is a perfect combination term that combines the information shock. So this is a condition in the patient with the etiology of the shock, namely the sepsis. So your best approach here is to really combine this information and to assign 3 LLTs. So here we are. We have to capture both the provisional diagnosis and also the associated symptoms. Here we are. We would code bowel perforation, spontaneous bacterial peritonitis, the 2 provisional diagnoses, and septic shock. Are there questions, Leander?
We've had a question again on overdose. I don't know if you want to take it now or at the end. And there's another one that is, if there are multiple symptoms with laboratory test results, all inferring a potential diagnosis, in brackets not mentioned, can we infer the diagnosis?
We come to this later on. And what about the overdose again?
The overdose is if it is not stated that there was an overdose, but the dose administered is higher than the dosage reported in the SMPC, to code the overdose. Do we have to code the overdose?
Well, this really depends on what your coding setup is. If you have a central coding organization that is coding out of context, you wouldn't be able to have access even to the suspect drug or whatsoever, and you would also not have access to the local label information or SMPC. So, but if you are coding in the case processing scenario, so if you have the full information of the case, then of course you know the drug, you can see everything, and if you have then the access to the label, to the local label, you have the country of origin as well, or the SMPC, you can of course classify accordingly as overdose if it exceeds the upper limit of what is mentioned in the SMPC or local label. This really depends. It's a process question. Yeah.
Thank you, Caroline. No other questions at this time. Thank you.
Thank you. Another frequent problem area is the reporting of conflicting or ambiguous information, and the slide provides two examples from the PTC document. If no clarification can be obtained, you will have to find an adequate coding solution for such verbatims. In the first example, the diagnosis hyperkalemia does not match the lab result that rather indicates hypokalemia. The recommended coding approach for such scenarios is to code to the respective abnormal MedDRA LLT in SOC investigations. Coding then covers the fact that the lab result is not normal, but doesn't make any assumptions whether it is below or above the normal range. By the way, coders are frequently confronted with numerical values for lab values that need classification, and it is really advisable to add one or two references like the Oxford or Harrison's textbook of medicine to the coding conventions that are to be used as a standard reference to ensure consistency of classifications. A different scenario is shown in the second example, where we are confronted with an ambiguous abbreviation that could indicate either genitourinary or gastric ulcer pain. If we cannot obtain clarification from the reporter, the best solution is to code to the underlying basic medical concept that is pain in this instance. If confronted with abbreviations, check in some references like dictionaries for medical abbreviations in order to find out whether on an international basis, this abbreviation will always mean the same thing, meaning that it is not ambiguous. MedDRA contains abbreviations, but only if they are non-ambiguous. Especially when receiving consumer reports in pharmacovigilance, vague information may be reported and there may be no chance for further clarification. Turned green is a nice example from the PTC document here. It could relate to the skin or tongue of the patient, but also to a drug like a capsule or cream that has changed color. So we do not even know if this is something that affects the patient. That is why we would code similar verbatims to LLT unavailable event. If we knew that there is something wrong with the patient, as shown in the second example, we would choose LLT ill-defined disorder. MedDRA includes several LLTs and PTs in SOC General that can be used for such vague scenarios where we know that the patient is affected, like this one, ill-defined disorder, but also PTs like general symptom or PT local reaction that can be assigned depending on the reported verbatim. So again, are there questions so far again, Leander?
No further questions. Thank you, Caroline.
Okay. So then let's continue. From what you've just heard, how would you approach this verbatim? Patient had an MI. Would you code to myocardial infarction, ill-defined disorder, MI, or unavailable event? What would you do? Patient suffered an MI. Oh, we have split of opinions here. So some of you would directly code to myocardial infarction, others would select MI, ill-defined disorder, or unavailable event. Unavailable event seems to be the preferred option. Let me close this poll here. And what we would, it may relate to myocardial infarction, but It could also, the abbreviation MI can also relate to myocardial ischemia or mitral insufficiency or mental illness. So can be an abbreviation for many different medical conditions. Mesenteric ischemia, also an option. So we can't assume that it means myocardial infarction. And can we select MI in MedDRA? So let's check in the browser again. If I enter MI, you can imagine that I get many, many results. Here we are, 2077 PTs, because this is, of course, a string that is available in many of the terms that are included in MedDRA. So we will have to narrow down our search. And with the advanced search option here, we can say exact match MI, and we would search. And here is MI, and you see, based on the legends that we have in the tool, if you have an LLT in red lettering with a red square around it, this is a non-current MedDRA term, a non-current LLT. So it was made non-current, of course, because it's an ambiguous abbreviation. It's grouped under myocardial infarction, but this really means if you find an abbreviation in MedDRA that is non-current, you can be sure it's an ambiguous abbreviation, like here, MI. So the best code assignment, what would it be? Not myocardial infarction, not MI, that's for sure. Are we sure that the term describes a condition in the patient? No, we don't, because MI may also be an abbreviation for medical inspection, so a physical exam. So that's why the correct assignment would be unavailable event. And most of you have gone for this code assignment. So well done. Let me know if there are any questions, Leander. Just interrupt me then.
Thank you, Caroline. There is a question. It's quite specific, but it's also, I think, an ambiguous term, so it does fit. How do you code reflux?
Oh, reflux could relate to many terms. So for me, it would. You also have these translation issues as well. Must not relate to a condition in the patient even. Somebody may have translated something into English who is not a native speaker. I'm not a native speaker either, but it could relate to a reflux from a medical device, for instance, that is not intended, something like that. So difficult. I would rather go to, if I cannot clarify, of course you would always try to seek for clarification, but if I couldn't clarify, I would rather go for unavailable event. Any more?
Thank you, Caroline.
Yeah.
Just one more, and for the turned green verbatim, can we code adverse event NOS?
No, because it would, the green, as we said, it must not be a condition in the patient. So an adverse event would mean it's a condition in the patient, and that's why you would go for unavailable event, because it could also relate to a product quality issue that is reported there with the turned green. And the NOS terms, I come to this later on. NOS stands for not otherwise specified. Yeah.
Thank you. No other questions. Thank you. Oh, actually, one just popped in. Can you clarify what's the difference in coding adverse events NOS? You're going to come to this. Thank you.
Yes, I come to this. Next topic. When coding investigational results, please remember the following, and this comes to the question that we got earlier. MedDRA includes medical conditions in the relevant system organ classes. plus related investigational results like lab results in SOC investigations. And therefore, it is important to make this distinction. It is a principal rule in MedDRA that you should not change internally. Remember the basic MedDRA coding rule, code as reported, meaning that if a medical condition is reported, code as such. And when an investigational result, like a lab value, for instance, is reported, select a term from SOC investigations. Never interpret a lab result as a diagnosis. And when receiving precise reports on investigational results, like in the first example, there are no problems. The value is clearly below the reference range and the verbatim can be coded to LLT glucose low. But often, investigational results are reported without units. Like in the second example, we don't know whether this refers to 40 milligrams per deciliter, which would be low, or 40 millimoles per liter, which would be high. So milligrams or per deciliter or millimoles per liter. Such reports are ambiguous and should be coded to a suitable abnormal LLT if there is no option for further clarification. In order to classify lab values as low or high, and I mentioned this already, not just decreased or increased, you will need standard references to decide whether the reported value is clearly below or above the normal range, as mentioned earlier. Quite frequently, a diagnosis is reported with the corresponding lab values, like in the first example here. In such cases, you are not obliged to capture the diagnosis plus the investigational results as long as these are consistent with the diagnosis. Because when a hyperkalemia is reported with an investigational result that supports the diagnosis, like in the first example here, splitting would lead to redundant information, not necessary to split code in such coding scenarios here. But when would splitting of investigational results become necessary? So let's have a look at the second example where 4 different abnormal liver function tests are reported. Increased alkaline phosphatase, increased SGPT, increased SGOT, and elevated LDH. So remember the fundamental principle, MedDRA coding rule, code as reported. So do not omit parts of the reported events. Do not lump the reported findings under one LLT like liver function test abnormal, but split and code each of the specific reported findings separately. And don't make a diagnosis out of these reported lab results. That was the question that we received before. Always differentiate between diagnosis and lab results. So looking for clusters, interpreting the data that were coded is part of the data analysis of the product experts. It's not a coding task. The coding task is to capture the information that we receive specifically and consistently in order to support subsequent data retrieval and analysis. So do not make a diagnosis out of investigational results. So another example for you to try. Testing showed increased serum creatinine and BUN with increased BUN creatinine ratio. What would you do with this one? Would you code to increase serum creatinine, BUN increased, blood urea, nitrogen creatinine ratio increased, or would you code to renal function test NOS abnormal? What would you do? Some of you would group this under renal function test NOS abnormal, but most of you tend to split code here. So let me close the poll. Thank you for joining. And we would select, of course, remember, we would always code specifically, so we would need to split code in order to code all this information that we have received by assigning increased serum creatinine, BUN increased, and blood urea nitrogen creatinine ratio increased. So we would not lump this. Always code as reported. Do not interpret, do not add information. You would omit information if you would lump this under some general LLT, like liver function tests increased or renal function tests increased. Now let's have a look at another example. The patient had aldosterone excess. The patient had features of aldosterone excess. What would you do with this one? Would you code to aldosterone increased, aldosteronism, or blood aldosterone abnormal? What would you do? So this example is tricky. And we have split of opinions here. Most of you are tending towards investigational results. Others say this is aldosteronism. Again, let me close the poll here. So let's look at the verbatim again. Here, no investigational result is reported. We are not told that the aldosterone was measured and resulted to be excessive. But it is reported that the patient had signs and symptoms, features of an aldosterone excess. It is a condition in the patient. And that is why we would select LLT aldosteronism under PT hyperaldosteronism that perfectly captures this medical condition in the patient. Other questions, Leander?
We've got one question. We sometimes have cases reported, back to our unevaluable events, we sometimes have cases reporting the patient was coded after treatment or coded blue. Should this be an unevaluable event?
Yeah, you don't know why. I would have to search in MedDRA myself in order to find something, if there is something that really would indicate the seriousness of the condition. I would definitely try to clarify this and ask for the reason. Cardiorespiratory arrest, myocardial infarction, pulmonary embolism, whatsoever. But I would have to look for a term that I would always try to find something more specific in order to capture the severity of the condition, the seriousness in this instance. Cannot tell it from, it's too specific. I would have to search MedDRA myself, although I'm working with MedDRA for many, many years now, but I still don't know it by heart. Too complex, too many entries.
Thanks, Caroline. And just on the example you're on, we had why not blood aldosterone abnormal?
Yeah, because it's a feature. Patient had features of aldosterone excess, and features indicates that the patient had signs and symptoms that relate to an aldosterone excess. And the correct term, so it's a condition in the patient. We are not looking at a verbatim that is describing an investigational result. And that's why aldosteronism is really the correct term here. Aldosteronism, if I go to the browser again, you will see it's a condition. Basic search again. And if I go for aldosteronism, you will see that it is a condition. Aldosteronism. If you have a typo in there, you won't get anything. If I click on the term, here you have hyperaldosteronism would be the PT. It's an endocrine disorder, so it's a condition in the patient. Yeah, and you see it has primary linkage is to endocrine disorders, secondary to metabolism and to vascular disorders. whereas, of course, aldosterone increased would or abnormal would reside in the investigation SOC. I hope this answered your question.
Thank you. No other questions. Thank you.
Okay. So let's continue. I have to speed up a bit so that we don't that we make it with our exercises at the end as well. So here comes the next advanced coding principle, combination terms. The first example on the slide refers to such a term, but not to a diagnosis with signs and symptoms as we saw earlier, but to terms that relate to the same overarching medical concept, but where one is more specific than the other. And the slide here shows two examples from the PTC document. Arrhythmia due to atrial fibrillation. So atrial fibrillation is the more specific type of arrhythmia, so we would code this verbatim to atrial fibrillation, because atrial fibrillation is an arrhythmia. Hepatic function disorder specified as acute hepatitis. Again, we code to the specific type of hepatic function disorder, the acute hepatitis. But sometimes you'll see MedDRA combination terms which relate to two separate medical concepts, for instance, combining a defined medical condition with its etiology or additional attributes. Remember our previous example with the sepsis and the shock, where we found a combination term, septic shock. And here we have additional examples. Retinopathy due to diabetes. You will find a perfect combination term combining this information, and it's diabetic retinopathy. Or rash with itching. You will find itchy rash. Or breast cancer, HER2 positive. So HER2 stands for human epidermal growth factor receptor 2, and its overexpression promotes the growth of cancer cells, so meaning that its presence has a significant impact on treatment decisions and also the prognosis of the patients, and it needs to be captured when reported. And again, you'll find a perfect combination term in MedDRA which captures the full information. LLT, HER2 positive breast cancer. If you get a verbatim representing a combination of relevant clinical information and no corresponding combination term is available in MedDRA, then you should split code. You should select more than one LLT to capture all relevant medical information. In the first example, we would split and code to LLTs diarrhea and vomiting. In the next example, a wrist fracture due to fall is reported. Again, capture all information. The fall may have been caused by the drug because it made the patient feel dizzy, for instance. So you have to capture all information to be able to search for it in your database, to be able to look for patterns and safety signals. Then we have a reported BRAF positive malignant melanoma. Again, split this information to capture both the specific malignancy and the gene mutation because it is relevant for therapy decisions and for the prognosis of the patient. Now it's your turn again. Here, a retinal disease from HIV with near total blindness, right and left, is reported. So more than one term is to be selected in this case. What would you select? Retinal disorder, HIV disease, blindness, HIV retinopathy, blindness, both eyes. What would you do? See you voting already. And the favorites are HIV retinopathy, blindness, both eyes. Perfect. Well done. Let me close it. So let's first look at the retinal problem. We have a reported retinal and HIV disease and could split and select retinal disorder and HIV disease. But HIV retinopathy is a perfect combination term for this retinal disease from HIV. So in MedDRA really contains quite a number of such combination terms. Look out for them and use them. Now, do we have to consider additional information in our verbatim for coding purposes? Yes, we have to code the subsequent complication, sequela, by assigning LLT blindness both eyes. So this finding cannot be considered a symptom of the reported HIV retinopathy, but represents a late-stage severe complication of the disease. And one has to differentiate between signs and symptoms of the diagnosis and late complications. So if this HIV retinal disease would have been reported with some ophthalmological investigations that were abnormal, then you wouldn't have to split code. But here it led to near total blindness bilaterally. And that's why this is a complication of the retinopathy, and that's why it needs to be split coded. Here we are. We would code to HIV retinopathy and blindness both eyes. Let's see if there are questions. Do we have questions, Leander?
Yes, we do, Caroline. Just on that one, can we assume R and L means right and left? I know in the verbatim we have it in brackets, but can we assume it's right and left?
Yes, I think so, because it's near. It's really it's specifying the near total blindness.
Thank you. And just one back to, I think it's the aldosterone example. Yeah. Why the test results have to be coded? Just bear with me. Why the test result has to be coded as ADR instead of in the section of laboratory test? Laboratory test.
Well, in the E2B guidance, you have the test name fields where you just put in the test name. But if you have abnormal values that are measured of specific tests, then you have to enter them as adverse events. So it's two different fields that you are talking about, and both needs to be filled. One with the test name, just with the test name. It just contains the test name, no further information. And of course, you have more information. If you have more information about abnormal, increased, decreased, low, high, positive, negative, whatsoever, you have to enter this as an adverse event because it contains more information. It really represents an abnormality that is detected in the patient.
Thanks, Caroline. And we've just had one more come in. It's a very interactive audience, which is great to see. Why do we code risk fracture in risk fracture due to fall if it was due to a fall and not the drug? Does it not lead to misinterpretation?
Wouldn't. Depending again on your drug, you don't know what the patient is taking, the age of the patient. Maybe the patient suffered osteoporosis or is taking a drug that causes osteoporosis whatsoever. Yeah, just code as reported. Do not interpret. The patient suffered a wrist fracture and due to a fall, and you would code both informations because you don't know the cause. You even don't know whether this was a traumatic fracture at all, because it could be either an osteoporotic fracture or even a fracture due to a malignancy, due to metastasis. Not in the case of wrist fractures, but in the case of other fractures, it may well be that it's rather a pathological fracture. Again, code as reported. Do not interpret too much. Yeah, think about it, yes, but do not interpret.
Thank you. And do we always code complication of event with diagnosis if it's mentioned in the case?
Yes. If there is a complication from the previous event, from the previously captured condition, then you would always split code. So that's what I said. You have to differentiate. So if you have like If you have a myocardial infarction with the typical signs and symptoms, sweating, chest pain, whatsoever, and the information that this then led to a myocardial dilatation, to dilatative cardiomyopathy, then this cardiomyopathy would represent a complication of the myocardial infarction. You cannot consider it a sign and symptom anymore. You have to split code that.
Thank you. And if the reporter does not specify the measurement unit, is it wrong to code the general unit used?
No, I wouldn't. Yeah, again, if you are in a central coding organization, coding out of context, you don't know the country of origin of the case whatsoever. If you're coding for pharmacovigilance, I wouldn't make this interpretation. So I would then code to abnormal, to the corresponding abnormal term. Unless there's no doubt at all. But this is really rare. Mostly these terms are vague, and then I would code to abnormal.
Okay, so we had a clarification on that if the reporter did not code AKI, for example, but discharge letter provided shows that they also had an AKI, should we be coding it?
Yeah, this is not a coding question. This is a data extraction, term extraction. So you always have to differentiate between term extraction from the case that is entered for this case report of the respective patient, and coding is only done on what is extracted from the case. So this needs to be extracted, and when it is extracted, of course, it needs to be coded. So AKI, of course, needs to be coded, but you can only code it when it's extracted from the information received.
Thank you. And then we had another one in relation to the blindness. So they had the same question about the blindness. How will that be distinguishable from an effect of a study drug? I'm not sure if you can answer that one, and I need to go back and clarify.
Causality is not our task in coding. So we capture what has been reported, and everything that needs to be captured, what can be captured, would be coded. And causality questions are not relevant when for coding, not at all. So let me continue, because otherwise we won't make it.
Thank you.
So medication errors. I will go through this very quickly because we have a separate webinar for this whole topic, medication errors and other types of unauthorized product use. So here we are. Many MedDRA users find coding of these incidents quite challenging. That's why we have this separate webinar. And here's now the MedDRA concept description of the term medication error. So for the purposes of MedDRA term selection and analysis of MedDRA coded data, medication errors are defined as any unintentional and preventable event that may result in the improper use of medication or even harm to the patient while the medication is under the control of those involved in the medication process, meaning physicians, pharmacists, nurses, patients, consumers, or their family members. So the second aspect that is highlighted in green here is really important to remember. These errors occur during product use in the medication process, when the product is under the control of the healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers, in other words, outside of the control of the healthcare provider, patient, or consumer. To better understand these concepts, please refer to the concept descriptions first, because they contain very useful information that will help you understanding these challenging terms. Also, I would like to make you aware of one additional PTC guidance document, the so-called MedDRA Points to Consider companion document. So this document provides more detailed guidance, specifically around medication errors and more examples to help distinguishing the different concepts. And another tip, the best approach for finding suitable terms is the top-down navigation in the browser in HLGT medication errors and other product use errors and issues. And you'll find all PTC documents under the menu How to Use and the sub-menu Support Documentation on the MedDRA website. So let me show you shortly where to find them. Here we are again on the MedDRA website, How to Use Support Documentation. Here we are. Takes a while. Here are the points to consider documents. And if I click on this little arrow here, is the MedDRA term selection points to consider document in different formats, in PDF format, Word format, where it's easy to cut and paste in order to produce your own coding conventions, HTML format that is easy to navigate. And there's a so-called redlined version that really highlights the changes that were made to the document, in the document, as compared to the previous version of the document. So if you are already familiar with the content of this document, you can just refer to this redlined version with the new MedDRA release in order to easily identify the changes. And here is the companion document in PDF and Word format. And if I click on it, you will see that it is quite, here the medication errors part, you have this, it starts at page 9 and we have lots of from 9 to 35. So a lot of information here, question and answers and examples for coding medication errors. So if you have to deal with these, this type of reports, it's really advisable to refer to this document in order to better understand how to classify these events, these incidents, one has to say. So let me again, here's the browser, we may have to go there. I also said in injury, poisoning and procedural complications, you have the HLGT medication errors and other product use errors and issues. And here you should really do a top-down search in order to find suitable terms. And this is all explained in much more detail in a separate webinar, so I won't go into this any further. If a medication error is reported with clinical consequences, like in the first example, patient was administered wrong drug and experienced hypotension, both the medication error and, of course, the consequence of the error needs to be captured. So the closest matches are LLT wrong drug administered and LLT hypotension. In the second example, it is reported that because of similar sounding drug names, the wrong drug was dispensed. And as a result, the patient took the wrong drug and experienced a rash. Here we have 4 interrelated events. First, the wrong drug was dispensed. And the report also states the contributing factor that the 2 drug names sounded alike. And the consequent error is the administration of the wrong drug, leading to a rash in the patient. So wrong drug dispensed, wrong drug administered, drug names sound alike, and rash would be the appropriate code assignments here. And in the third example, it is reported that insulin was given using the wrong syringe. Here we have 3 interrelated events. The insulin given in the wrong syringe is the first thing that happened. As a result, the patient then received an overdose and as a consequence developed a hypoglycemia. The medication error is the administration of the drug in a wrong device. And because the overdose results from this error, it is not intentional but can be specified and also coded as accidental overdose. And the result is the hypoglycemia in the patient. You have 3 LLTs here that need to be assigned: drug administered in wrong device, accidental overdose, and hypoglycemia. If a medication error is reported and it is made clear that there were no clinical consequences, the PTC guidance provides us with two coding options. When it is reported that an intramuscular formulation medication was given intravenously instead of intramuscularly, but the patient did not experience any adverse effects, the preferred option would be to code the medication error, the wrong route of drug administration alone. The most specific LLT would be intramuscular formulation administered by other route. The alternative approach would be to not only capture the error made, but also the fact that no subsequent complications occurred by assigning no adverse effects. So again, you have a preferred option here in the guidance and an alternative option. And you are free to choose either option, but document your rules and ensure that they are applied consistently. Sometimes potential medication errors are so just potential medication errors are reported. Such incidents should also be captured as specifically as possible, depending on the regulations, because regulation may differ between different regions. So make yourself familiar with the regulations that apply in your area. Also, the contributing factors should be captured, like in this example from the PTC document, where it is reported that a pharmacist notices that the names of two drugs look similar and is concerned that this may result in someone getting a wrong drug. LLT drug name look alike captures the information about the contributing factor, and LLT potential for medication error, wrong drug, indicates that there is a potential for a medication error, including the error type. So why do some regulators want to receive this information? Well, in such scenarios, no medication error happened yet, but could, of course, occur in the near future based on the reported contributing factors, like drug name confusion, etc. When understanding the background for these potential errors, regulators can take steps to prevent errors even before happening. So depending on your local requirements, do not omit such information, but capture all relevant information when receiving similar verbatims and code both the potential for an error by selecting one of these similar LLTs, and also code the contributing factor or factors, yeah, drug name lookalike or whatsoever. Although not being an adverse event, such incidents may need to be included in periodic safety reports. Are there questions, Leander?
If the patient says he's going to take the prescribed drug without the doctor's prescription, but has not taken it, would you code it as prescription drug use without a prescription? I don't know if that's too specific and out of scope for us.
I would say that it would really recommendable if you have to deal with such scenarios that you attend the medication error webinar. It takes too long now. I think we are running out of time. I'm sorry, I cannot answer all these questions. But if you attend, the next one is, I think, in Russian. I will show this, and I will provide the webinar in mid of June, I think. So if you are interested, you can join there, or you can watch one of the recorded sessions on our YouTube channel.
Thanks, Caroline. Yeah, the next medication errors webinar for you is the 18th of June. I've sent a link to a couple of people. We've had a few questions in that I knew were out of scope. Thank you.
Okay, so we will now address a more specific topic that may also relate to medication errors, that is overdose, toxicity, and poisoning. If overdose, poisoning, or toxicity is reported, extract this information and code accordingly. Poisoning by drugs and drug toxicity are considered synonyms in MedDRA. You will find the relevant terms under PT toxicity to various agents. You may ask yourself when to consider a high dose as overdose. Well, you saw the concept description in the browser that I've shown before. It says, for the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose in quantity and/or concentration. In other words, an excessive dose. If an overdose is reported with clinical consequences, you code both the overdose and the resulting events, of course. And if there are no clinical consequences, again, you have two options that the document provides you with. The preferred option would again be to code the overdose only or accidental overdose. But you also have the option to select the alternative possibility, that is to code to overdose and no adverse effect. Another advanced principle addressed in the PTC document is death and other patient outcomes. Death, disability, and hospitalization represent patient outcomes and are normally not captured as adverse events or adverse reactions. But if one of these outcomes is the only information received, then you would code as specifically as possible. And also, if a death term would add relevant medical information, you would code it in addition. And here's an example. Patient experienced a rash and had sudden cardiac death. If you would ignore the information sudden cardiac death and not capture it, you would, of course, omit relevant clinical information, because it can be considered unusual that a rash leads to sudden cardiac death unless the patient had additional medical problems. So you have to code both the rash and the sudden cardiac death. You would also try to get more information why the patient suffered sudden cardiac death, but if this is the only information that you have, you would split code. Suicide and self-harm is another special topic addressed in the PTC guidance. So when coding suicide attempts or completed suicides and self-harm, clearly distinguish between these three scenarios. Be as accurate as possible and handle these terms consistently. Do not assume that an overdose, even if it is reported as intentional, relates to a suicide attempt. Same holds true for reports on self-injuries. If suicide attempt or suicide are not mentioned in the report, only code the intentional overdose or self-injury. Remember the basic coding principle always. Do not interpret what has been reported by adding information. Code as reported. And if a suicide attempt has a fatal outcome, make sure to capture it as completed suicide. The outcome makes a big difference here and needs to be considered when coding. And this was actually what an inspector checked in a drug safety database of a pharmaceutical company. He asked for all cases that were coded to LLT and PT suicide attempt, but with a fatal outcome, in order to assess the quality of data entry and coding in this database. So these events, a suicide attempt with fatal outcome, should of course have been coded to completed suicide and not to suicide attempt. Next one for you. Here we have a medical event with an outcome. So what term or terms would you select? Death from cerebral hemorrhage, sudden death, death, cerebral hemorrhage, or brain death. What would you do with this one? Let me speed up a bit. Cerebral hemorrhage, yes, you are on the right path here. Most of you, we would code to cerebral hemorrhage because this is the event leading to death. Death, so the fatal outcome or an outcome like hospitalization, are captured in separate database fields. They do not have to be captured if we have a reason for death or a reason for hospitalization. So here the correct code assignment would be cerebral hemorrhage. Other questions so far, Leander?
There are no questions, thanks, Caroline.
Okay. So cerebral hemorrhage would be the correct one. Next principle that I would like to share with you relates to drug interactions. This term drug interaction covers interaction between drugs, including biological products, but also between drugs and foods, devices, alcohol, etc., etc. If an interaction is reported, then capture the interaction and the subsequent medical events, both. And here's an example. Patient drank cranberry juice, which interacted with anticoagulant drug, causing an INR increase. It is clearly stated by the reporter that an interaction occurred, and we should capture this information. Make sure to code the interaction as specifically as possible. Here it is a food interaction, but you may also receive reports of drug-drug interaction, drug-alcohol interaction, device interaction, drug-device interaction, drug-disease interaction, herbal interaction, or radiation interaction. So many terms available in MedDRA for such specific scenarios. Always code as specifically as possible. All these concepts are available in MedDRA. But what if a reporter does not specifically state that an interaction occurred, but only mentions that 2 or more drugs were taken together and reports a medical event afterwards? In such instances, you should not assume an interaction just because the patient is taking several drugs, but select terms for the reported medical events only. And here's an example again. After taking an antihistamine along with her prescribed proton pump inhibitor, a 53-year-old woman developed vertigo. What would you do with this one? Would you code to drug interaction NOS, vertigo subjective, vertigo, and or drug interaction? What would you do? So most of you are going for vertigo, and most of you are going for drug interaction as well. So let me close the poll. We are not told that an interaction occurred here. We should not assume it. The only thing that we know is that the patient took 2 drugs concurrently. We should not assume that an interaction occurred, but code as reported. And we are not told that the vertigo was subjective, that it was only a feeling of vertigo. It's a diagnosis. It was a vertigo. We are often asked when to use NOS terms and when not. Actually, it doesn't really matter, but good practice is to only select NOS, not otherwise specified terms, when it is clearly stated in the verbatim that the condition cannot be further specified. We had this question before. So this is the explanation for it. So what is reported here is just the condition of vertigo, not a drug interaction. There is only a temporal relationship between the intake of the 2 drugs and the vertigo. It is not reported that an interaction between the 2 drugs has caused the vertigo. And one should not use qualifying terms that are not in the report. So the correct assignment would be vertigo here. So only code to interaction terms in MedDRA that are available in MedDRA when an interaction is actually reported, not just when there is a timely relationship of a certain event after taking several drugs. Now let's have another short break here to address questions, and then we will continue with our exercises.
Thanks, Caroline. If during the medical assessment we find out there's an interaction, should we add it?
This is something that does not relate to coding. This is really a term extraction question, and it depends on your policies. I cannot answer that.
Thank you. No other questions.
Mm-hmm. So here we are with our coding exercise. We may not be able to cover all of them because of time constraints, but I wouldn't like to rush through these exercises. That would not be a good condition for understanding the different coding scenarios and for learning how to handle them. So let's see how far we get. It is sometimes really difficult to find the right balance between the number of exercises that we provide and the time spent on them. In the feedback that we receive after our training sessions, some participants would like to see fewer examples with more time for discussion and explanations, while others would like to see more examples and not spend too much time on individual verbatims. And these expectations are really hard to bring together. So I will try to do my best here. As already mentioned last week in the webinar Coding Basics, before searching in your browser, it is always good practice to check what exactly has been reported. First, look at your reported term, the verbatim. Is it a clinical condition, a diagnosis, sign or symptoms, an indication for use, test result, an injury term? Does it relate to a procedure, a medication error, or another product use issue? Is it a product quality issue that is reported, or a social circumstance of the patient? Is it a device issue, a procedure complication, or a combination of these? So the type of reported term will influence where you would look in the browser to find the closest LLT or LLTs that best match your verbatim. If it is a medication error, you would look into the SOC injury. If it is a product quality issue, you would search in the product issue SOC, etc. So now let's start with our exercises, and you can test yourself in applying the advanced principles that we just have discussed. And for actively participating, you can use the MedDRA browser, the web-based browser. I've shown you where you find the shortcut. Here is the username and the password, but you can, of course, use your own credentials or your own MedDRA browser if you have an in-house MedDRA browser available. So this is the temporary password, just to let you know. It's only valid for a few days. So don't expect this. It is changed next week. Here again, the QR code for accessing the poll questions, just in case you have lost the connection again. And here is our first example. It is reported that a patient became colorblind in adolescence. How would you deal with this one? Became colorblind in adolescence. Which LLT would you select? Color blindness, blindness color blindness acquired, or color blindness acquired in American English? What would you do? Most of you are going for color blindness acquired. Good to see that. But some of you are voting for color blindness as well. So let me close the poll here. The key thing here is that color blindness is normally a congenital disorder, and that is why the LLT color blindness or the LLT blindness color are placed under the congenital SOC in MedDRA. But because we are told that the patient became colorblind in adolescence, we will have to look for a term which includes the information that the condition was acquired. It was not congenital. And one additional comment. You see British and American spelling on this slide. The event was reported in American English, and that is why you should go for American spelling of color blindness, meaning the last LLT. In practice, it really doesn't matter which one you choose, because it's from the medical perspective does not make any difference at all. But it would be good coding practice to follow not only the actual wording of the verbatim, but also whether it is spelled in British or American English. So match the spelling of the verbatim to American or British English at the LLT level. On the PT level, you will always find British English based on MedDRA naming conventions. So the correct answer here is color blindness acquired It reflects the acquired nature of the condition and also the appropriate spelling based upon available American, British, English spelling options. Are there questions, Leander?
No questions, thanks, Caroline.
Next one. Turned very greasy. What is reported here? Is it an ill-defined disorder in the patient, an unavailable event, a skin, maybe the skin got greasy, or would you code this to unavailable reaction? What would you do? Turned very greasy. Yes, you're on the right path here. Most of you got it right. And let me close it here. Is it the skin or the hair that got greasy? Turning greasy may not even affect the patient, but may relate to a medicinal product again, like an ointment which has turned more greasy. That is why I wouldn't go for ill-defined disorder. And I wouldn't make the assumption that the skin of the patient turned greasy. We also don't know whether this was a product quality finding. So LLT unavailable reaction would not fit either, because we don't know whether the verbatim describes a reaction to a medicinal product. It could be a quality issue as well. So the best LLT to select here is LLT unavailable event, and most of you got it right. So thank you for joining. Well done. So selection of LLT unavailable event would be the correct decision. Any questions, Leander?
No questions, thanks, Caroline.
I hope that you still raise questions. So we are a bit short of time, but still, please raise questions. Next, a patient reported a medical problem. How would you handle this verbatim if no additional information can be obtained? This is now the flip side of what we have just seen in the previous example. Here, obviously, the patient is affected. Which LLT would you select? Is it an adverse event? Do we know that? Or shall we code this to LLT unavailable event like before, or unavailable reaction? Do we know that this was a reaction to a medicinal product or something else? What would you do with this one? Adverse event, unavailable reaction, or ill-defined disorder. Again, most of you got it right here. Ill-defined disorder would be the correct code assignment, because in our case, if no additional information is available, the term reflects the fact that the patient was affected by an unspecified, vaguely reported medical problem. So coding to LLT adverse event would imply that the patient was exposed to a medicinal product or study drug. This verbatim could relate to the medical history of the patient, or could be an event in a follow-up period as well with no drug exposure. We don't know. And the reaction term would even imply causality. So the correct assignment is LLT, ill-defined disorder, because the patient is affected by a medical problem. And I think we have addressed this in detail during the session, how to differentiate these concepts. Next exercise. A 2-year-old boy accidentally took his mother's medication. Which LLT would you select for this one? Accidental overdose, accidental exposure to product by child, wrong patient received medication, accidental drug intake by child, unintended ingestion of product by child. What would you do? Let's see what you're going for. Accidental drug intake by child. Most of you got it right. Some of you would also select accidental exposure to product by child. Let me close it. Let's look at these proposals. Was it an accidental overdose? We don't know what type of medication the infant took and how much it was, so we cannot assume an overdose here. Is it accidental exposure to a product by child? An accidental exposure could either be an inhalation or also dermal exposure or an accidental contact with the eye. But we know that the medication was ingested. We have more specific information. We know that the child took the medication of the mother. And product would also be too vague. We know that the child accidentally took a drug. Product could relate to other medicinal products like devices, for instance. This LLT also applies to LLT unintended ingestion of product by a child. So we know it's a drug, not just a product. So these LLTs are too vague. What about LLT wrong patient received medication? Is the child a patient who received the wrong drug because an error was made by the HCP or a family member? No, the child was not supposed to take a drug at all. This coding scenario describes an accidental exposure, and that is why accidental drug intake by child is the most specific LLT we can select for this verbatim. So most of you got it right. Well done. Here we are. Accidental drug intake by child would be the correct LLT selection. Are there questions, Leander?
Yeah, we've had a couple of people write in on this one. It says took. How can we know the child actually ingested it? And then another person asked, can you assume that took means ingested?
Yes, I would assume that it was ingestion, because if we would have just taken it to look at it, it would not have been reported. So you're right. It's obviously a consumer report, but if it's a case, if it's reported as a case, it would not be reported if the boy would just take it and look at it and then put it away again. So took, I would take worst case as an ingestion. Mostly in
Thank you.
PV, you take the worst case approach.
Thank you. And then somebody else has come in and said, what about inhalation or ointment?
Well, it was taken, and I would take the intake. I think an inhalation would be too difficult for a child. Usually, I would rather assume it's a medication or capsules, tablets, whatsoever that he took.
Thank you. No other questions.
Good, thank you. Next one. What would you do with this one? Hyponatremia, and we are provided with a lab value for it. Would you code to LLT serum sodium abnormal, hyponatremia, hyponatremia, or serum sodium decreased? What would you do? What would you select? We have a diagnosis here and a lab value. The question is whether this is consistent or whether there's something wrong in this verbatim. And most of you are going with hyponatremia. Some of you vote for hyponatremia and some for serum sodium abnormal. So let me close this again. So this example refers to a principle that I've shown before when talking about conflicting information in a report. Here we have a conflict because the reported diagnosis is hypernatremia, whereas the reported lab value refers to a low sodium level, because the normal range for blood sodium levels is 135 to 145 milliequivalents per liter. So if no clarification can be obtained, then such a report should be coded to LLT serum sodium abnormal, because we do not know which part of the information provided is correct. And here we are. So we would code to serum sodium abnormal. So we saw a similar example in the PTC document before, referring to potassium abnormality. And as mentioned before, it is important to be familiar with lab reference ranges and also to define a reference for tests in your coding conventions so that lab values are classified consistently. Any questions, Leander?
There is one. It's not on what we're currently, but I don't believe this question was answered, so I'll ask it again. If we don't know what the unit is, then how do we know the value is abnormal?
Yeah, because it's reported. It's reported, and again, you would go worst case in the GPV, in the PV scenario, in pharmacovigilance. So it is reported. Something is wrong there. Otherwise, it wouldn't have been reported, and you would go worst case. And if you don't get more information, you would go to a respective abnormal term.
Thank you. And just on this one, we've had, what if it says hypernatremia in brackets serum sodium equals 115?
Well, then you wouldn't know exactly. I don't know. I wouldn't look. I would have to look into a reference book again myself in order to see what other units are available and whether this could really relate to a normal value. I don't know that by heart. So this is the usual way you put the units in. So I would have to look for it in a reference book as well. So that's why it's really important to have such a reference defined in the coding convention so that you have an easy access to it and you can easily see whether this is an abnormal value or normal value. Even if you don't have, so if you have an abnormal value, if you don't have any unit here, I would go with the hypernatremia only.
Thank you. And then somebody said if we had natremia increased with this value instead of hypernatremia, do we choose the same PT?
Natremia increased. That's very specific. So it could be that the patient, so it would be quite a low value actually. Yeah. So I would always try to query this. Yeah. It's really a very low value here. I would go with it normal. If you don't know, if you don't have more information, it's really difficult. I would go with it normal.
Okay, thank you. I think that's it for now. Thank you, Caroline.
Next one, the patient reported a loss of smell and thought that he might have a COVID-19 infection. So how to handle this verbatim? Would you go to anosmia, suspected COVID-19, loss of smell, or COVID-19? What would you do? Always remember the principles that we have. So loss of smell, suspected COVID-19 are the favorite choices here that you have selected. Well done. Let me close it. So most of you have selected the loss of smell, suspected COVID-19. So a very specific term here. This is perfectly right. Anosmia is the medical term for loss of smell. But we always try to be as close to the wording of the verbatim as possible. So that's why loss of smell is the correct answer here. Here we are. We would go to suspected COVID-19 and loss of smell. Because you know that it might have, so it's a suspect diagnosis. That's why we have to code the respective symptom in addition. If just a COVID-19 infection would have been reported with a loss of smell, then of course you would not be obliged to code the symptom in addition if it was a confirmed diagnosis. Remember what we discussed before. Any questions?
No questions, thanks, Caroline.
Next one. She was abused by her husband. What is that? Is it a physical abuse? Would you go to battered wife? Would you go to spousal abuse or to victim of spousal abuse? What would you do? Again, let me check. So we have split opinions. Most of you are voting for victim of spousal abuse, others for spousal abuse. Let me close it and let me show you shortly in the browser. So this was a victim of spousal abuse because the wife was affected by the abuse of her husband. So if I click, right mouse click, go to browser, then I can see that this term is grouped in social circumstances, under HLGT legal issues, crime victims. And if I open the legal issues, you see that we have an HLT for the crime victims and also for the criminal activity. So for the abusers, we have abuser term and victim of abuse terms. And we have, of course, victim of spousal abuse, battered wife. We don't know whether this was really physical abuse, could have been psychological abuse, verbal abuse, whatsoever. We also don't know whether it was a sexual abuse by the spouse. So victim of spousal abuse would be the correct answer here. And you see that we also have PTs, many PTs for criminal activity, under those also spousal abuse. So this is the abuser, spousal abuse. Here it is. Here we are, victim of spousal abuse. Any questions, Leander?
No questions, Caroline. Thank you.
Okay, then here, I think it's our last one. Yes. A 27-year-old woman took a two-week course of antibiotics during her pregnancy. She did not experience any side effects. So what would you do with this one? A woman took a 2-week course of antibiotics during her pregnancy and she did not experience any side effects from it. No adverse events. Maternal exposure during pregnancy, no adverse effect. Normal pregnancy, would you assign one code? Would you split code? What would you do? Most of you would go for maternal exposure during pregnancy and also code. Some of you would also code no adverse effect and or normal pregnancy. So the points to consider guidance provides us with clear instructions here. So let me close it. The preferred option is to capture the exposure during pregnancy only, but you may also choose to split and code both the maternal exposure and the fact that no adverse effect occurred. Whatever you do, document your rules in your coding conventions again and apply these rules consistently. During this course, we always refer to the preferred option, so we would only code the maternal exposure and ignore the aspect that no adverse effect occurred. We do not have to capture that. And coding to normal pregnancy would be definitely wrong because we have no information whether the pregnancy was normal. We just know that she had no side effects from the antibiotics. Again, do not interpret, do not add information, just code as reported. And here is a screenshot of the related guidance and the points to consider document. You see, maternal exposure during pregnancy would be the preferred option for such scenarios, but you could also take the alternative approach. So here we are, maternal exposure during pregnancy would be the preferred option. And just a screenshot of the MedDRA browser in order to show you what type of PTs are available under HLT exposures associated with pregnancy, delivery, and lactation. So 2 PTs are quite vague. They can be used when it is not clear who was exposed during pregnancy. The next 5 should only be used when fetal exposure during pregnancy is reported or suspected by a reporter. The next ones here, the next group, represent exposures of the mother during pregnancy, and the last 3 exposures of the father during pregnancy of the partner. So make yourself familiar. You see, MedDRA is quite granular in this area. So make sure to really select the correct LLT and PT when coding such scenarios, such reports. So now we come to the pearls, to the tips that we can provide for coding. First of all, this is also what I've shown last week. MedDRA can, of course, not only be used for coding adverse events, adverse reactions, but also to code indications for use, to code medical history of patients, surgeries, and post-procedural complications. Everything that you see in red here can be coded with MedDRA. Whenever you are searching for a suitable term for a verbatim or for terms from a narrative like we saw before, first try using the actual words of the reporter. You better use word stems, like for example pancreas, to cover both pancreas and pancreatic for your search. Because if you are too specific in your search, you may not find any results. And you should use singular terms, not plural terms. And replace words with synonyms if you don't find a suitable hit in MedDRA at first. Like, for example, replace intentional by deliberate or unintentional by accidental when coding unauthorized medicinal product use. Or leg by limb, or lower limb, or extremity, or lower extremity. If you have found a somewhat suitable term, be aware of MedDRA specificity and always look for LLT for other LLTs under the same PT that may even better capture the verbatim, and also look for sibling PTs in the same grouping, because there may also be PTs that better capture your verbatim, that include additional information for the reported condition, as for example demographics, acute or chronic information, post-procedural occurrence, etc. Remember the example where we looked at the verbatim reporting a drug exposure by child, where we saw that there is an accidental product exposure, but also a separate PT for accidental product exposure by child. And if you have found a suitable term, always check the hierarchy, where the term lies in MedDRA, and do this in order to reassure yourself that the hierarchy represents your reported condition correctly. Remember our example with the acquired color blindness. If we had chosen just color blindness, it would have been in the congenital SOC, and that hierarchy would have been wrong for our coding scenario because the verbatim was referring to an acquired condition. When searching for suitable terms, use the top-down and bottom-up navigation. And if you have difficult verbatims, use available resources for clarification, among those also the concept descriptions that you can find in the MedDRA browser. And use the advanced search function or restrict your search to a SOC to narrow down your searches when needed. For example, when you get a long list of potential hits in the browser, like in our example today, where an MI was reported. And of course, you should get more coding training and of course coding practice via high coding turnover. Because the more you code, the more experience, the more professional you will get, the more accurate and consistent your coding output will be. So this is what we have addressed today, and this is now your last chance for questions. Do we have questions, Leander?
We have a couple of questions. So we had one that popped in just on the last example. Why is the best choice not to use no adverse effect?
For the last one?
Yeah.
Well, this is due to the points to consider document. So the preferred option is to just code the maternal exposure. Usually would, of course, if you have an adverse event reported, you would also code this. But mostly the preferred option, if you have an interaction or an overdose or an exposure during pregnancy with no adverse effect of this event, then the preferred option in the PTC document is always to not code it. But you have the alternative option to code it, of course, if you would like. It depends on your company's policy.
Thanks, Caroline. And then we've had a couple of pregnancy-related ones. So if a pregnant woman takes the drug, is the mother and the fetus exposed?
No, usually not. Not always. So you have the placental barrier, and not all drugs are crossing this barrier. So it really depends. It's a product-specific issue. So usually you would code the maternal exposure because it's clear that the mother took a drug, but you would only select fetal exposure either if you know the product and it's clear that it always crosses the placenta, or if it's reported as such.
Thank you. And then should trimester of a pregnancy be additionally coded for maternal exposure?
Yes, you have, of course. I've only shown the PT names in my slide, but you have very specific LLTs underneath. So if you have the trimester, first trimester, second, third trimester, you would of course try, as always, to code as specifically as possible.
Thank you. And then we've had a couple of people ask about certificates. So for those that missed the explanation at the beginning, if you stayed for the whole webinar, within 2 business working days or after 2 business working days, you'll be able to download your certificates through the self-service application. And that's it for questions. Thanks, Caroline.
Thank you, Leander. So here again, some information about MSSO contacts, the website, email of the help desk, a link to the frequently asked questions, the link to the MedDRA browsers, and the training schedule and the MedDRA support documentation. I've shown you what you can find there. This is what you can see under training schedule. So the next MedDRA coding basics training will be provided in French. The advanced MedDRA coding, this is the one that we have today. There will be another one offered in Korean, also in French and Chinese language. You see that we are offering these webinars in different language, also Russian. We have more coding training for more advanced coders, more experienced coders. We provide the Let's Code Together webinars. So the next one will be next Tuesday. My colleague Jane and I will provide it. This is a workshop format, and you will get, if you register for it, you will get the verbatims that we will discuss at this webinar beforehand so that you can prepare for the discussions. You see it's also provided in Russian in June. And here are the medication era webinars that we offer. And the next one here in June in English will be provided by myself in June, as Leander mentioned already, 18th of June, but we also have it in French provided by my colleague François and in Russian by my colleague Yelena. This is something that I would like to show you just shortly if you are not aware of it already. So if you go to the MedDRA website and you click on contact here, this page will open and you see that you can contact us via social channels, also via WeChat and WhatsApp channels in different languages. What is important and helpful is a YouTube channel of the MSSO for MedDRA. So here you find recorded sessions of all of our webinars provided by the different trainers. So if you can't make it to a certain webinar due to other commitments, you can always listen back to these webinars and also listen to the webinars of other colleagues, because everybody has a different style of presentation, or also different languages like Spanish here, Chinese, Brazilian, Portuguese, whatsoever, Chinese, Korean, and Russian. So this is what I wanted to show you. Sorry for being a bit late. But with this, we are coming now to the end of this webinar. I hope you found it useful. I hope that I could answer your questions, and I hope to meet you again in one of the trainings that we offer. So thank you for your interest in today's topic and for your really active participation. And a big thank you also to you, Leander, for your great support today. So enjoy the rest of the day. Wherever you are, and goodbye for now. Bye-bye.
Thanks, everyone. Bye-bye, and thanks for your feedback. Bye-bye.